We have Dr. Ann Hyslop with us today. She's from Stanford, as well as Dr. John Stern from UCLA. Welcome.
Good morning. Appreciate your interest in this question. It's really it's a difficult question for anyone facing this possibility of surgery. And I promise you I'm not going to answer the question completely because there's no simple answer to the question. The first talk of these two is going to be my talk, which is more conceptual, and then maybe some examples will come in the second talk, and then we'll have a chance for some discussion as well. Sooner than you think kind of presupposes what you think, and maybe it's better to say maybe sooner than you may think, because there's such a variety of experiences and needs. So to frame the question, I'm going to say that treatment decisions in general, whether it's surgery or medicine or anything, in all of medicine, depends upon knowing what's going to happen in the future. Meaning if you know the problem's going to go away tomorrow, why treat it? Unless it's going to be urgent today. And often in epilepsy, we can't know that fully. It's difficult to intuit. It's difficult to plan out. But we still need to make plans. And that's really the crux, the fundamental of the problem with surgery is having an overall sense of where things are going and an overall sense of how we can help. Some fundamentals. Surgery is considered when medications fail. And so standard of care, the approach overall, is try medications first when you're treating epilepsy. And it's when those medications fail, we can define failure in many ways, that surgery should be considered. Surgery also should be considered only when there's a likelihood that it's going to be better than the medications, better than trying another medication. That's fundamental. And this might seem obvious, but sometimes the obvious is worth saying. But then lastly, surgery is not one thing. We have a variety of approaches to surgery. I think some of you may have been here for the prior talk. And figuring out what matches which patient is a nuance. It's an important part of the decision making, and it really is part of a relationship between the doctor and the patient. So my goals today are really to talk through some of those issues. I came across this reference to this cartoon actually in an article about artificial intelligence, and the description is that this is where we are in the world now. We are actually over the cliff, but we just don't know it. I'm a Wile E. Coyote fan. And the question for epilepsy surgery is sometimes we don't realize where we are because we're still trying to make things work. And readjusting our perspective is the first step towards success. So very briefly, we're going to talk about what is drug-resistant epilepsy, because I said earlier that surgery is for consideration when medications fail. That would be drug-resistant epilepsy. What's been called in the past drug-refractory epilepsy. We don't use the word refractory anymore. That's just to let you know that those things are meant to imply a similar reality. What is surgically treatable epilepsy? Not all epilepsy is surgically treatable. Well, different ways. And what is urgent? I was asked to bring up the issue about urgent for the timing. And then, most importantly, how do we judge success? Because if the point of surgery is to be superior to medications, how do we decide what's superior? What are our goals? What do we want in the end after a treatment? So drug-resistant epilepsy has a definition. And the definition is a formal one coming from the International League Against Epilepsy, which is this large international organization to which many national societies, including the American Epilepsy Society, is a member. And so globally, it's defined as the failure of two appropriate anti-seizure medications that are being well tolerated, not causing serious problems, to provide sustained seizure freedom. And about 1/3 of people with epilepsy are thought to have this. So it's a real problem. But it may actually be a larger problem than that, because there was a US Centers for Disease Control study a few years ago that showed maybe half of Americans, at least, who have epilepsy have had a seizure in the past year. We don't know from that study why they had the seizure, but it suggests that 1/3, which comes from a very well-structured one center of experts, might be an underestimate of the problem, maybe larger. Now, I would put sustained or unsustained in italics here, because part of the problem here is what if a person does well, they have no seizures for some period of time, and they have one seizure, then they have no seizures for a while. What is sustained? And so this is part of the problem with trying to figure out when to go to surgery, is this really frustrating reality where for some people with epilepsy, the seizures come and go, and there's not a sense of whether it's improved or whether maybe the medications have finally worked, is the feeling. And that is another reality that has to be dealt with going forward. So we do have a heads up, or a leg up, maybe is a better way of putting it, thinking about the cause. So etiology means cause. And there's been several studies, this is the classic one, looking at the cause of the epilepsy for an individual and the likelihood of having more than a year of seizure freedom. And there's a relationship. And so sometimes when a person comes in and says that, I think medications are working, but they're really not, it's unclear, knowing the cause can be helpful in figuring out how much to trust the success of the treatment. And so this is a list of different causes. I'm not going to get into this because that's not for this audience. But my message is that understanding the cause of the epilepsy does inform somewhat your expectation for whether medications are going to be successful. Nothing is 100%. This is the real world. You can't say that it's 100%. But it does help make that decision about when to go to surgery. This is the paper I'm not going to get into in depth, but I want to bring up the important element of epilepsy which goes beyond the cause. This is about predicting who's going to have drug-resistant epilepsy at the time they're diagnosed with epilepsy, which is before they even start treatment. It was a large study involving 250,000, almost 300,000 individuals, and it was based upon looking at claims for medications and following people forward through a national survey. This comes out of what is emerging now in healthcare research, looking across very large populations and trying to figure out what we can intuit or understand from that large group in a way that we can't by having a smaller group in a more structured study. And so it was 28 million prescriptions were looked at, 174 million coding for diagnoses, and trying to figure a pattern of response. And the study showed a significant predictability. It's not great. It was about 70, I'm trying to read the small print, 70% predicted. But the reality of it is that the factors that were predictable were not about cause or anything else in this study. It was about who these people were, how old they were, how healthy they were, whether they had other medical problems, whether they actually saw a neurologist or not, and what type of insurance they had. And so I think what we have to think about for epilepsy is that it's not just the cause, it's also the social determinants of health, which is a term that's used in healthcare research now, that people who are struggling, who have overall poor health, may have a progression toward further problems. And so interventions to raise that situation. Some things can't be reversed, like age, but thinking about overall health, like being on a cholesterol drug, not that cholesterol drugs cause epilepsy, the point is that overall health will affect seizure control. So the surgically treatable epilepsies, and I said epilepsies as a plural because there's not one disease epilepsy, as I figure many of you already realize. Epilepsy is really an umbrella term for many different conditions. But the conditions that are treatable with surgery could be listable. It's not that complicated. We think about a condition called mesial temporal lobe epilepsy, which is where the epilepsy is due to seizures arising from a portion of the temporal lobe. The temporal lobes are here on the sides of the brain. We think about epilepsies that are due to a circumscribed or a well-identified abnormality, like a lesion, or it could be an injury within one region, where the seizures are identifiable and can spread from there. These could be something a person's born with or something that they acquire. We think about epilepsies where it's diffuse across one hemisphere, one side of the brain, where it's not well identified, but that still can be treatable. And then for people who have the epilepsies that are associated with developmental disability, intellectual disability, where there's a diffuse dysfunction within the brain that ends up compromising concentration, memory, language, coordination. There are other surgical treatments that can be helpful, even if they don't provide this high rate of seizure freedom. I think the prior talk listed some surgeries, but I'm not sure how many people here were in the prior talk. But the surgical options go across a range of removing just the circumscribed, the area that you can see on the MRI is small and related through an EEG test to the cause, or maybe the region around it, because the region around a lesion is sometimes the important area, because a brain tumor doesn't cause seizures, it's the injury the brain tumor produces to the brain tissue around it that causes the seizures. We can do ablation, meaning to cut, but using heat and a laser. So it's a different way of affecting the tissue. And then there are larger procedures which might remove a larger extent, like one side of the brain, one hemisphere, or disconnection between the two hemispheres. And then lastly, within surgery, we often include the possibility of devices, which are stimulation devices, sometimes called neuromodulatory devices. I think stimulation is probably more accurate and more to the point. They're providing electrical stimulation. So we have this range of possibilities. Thinking about the urgency, this is one graph from one paper from approaching 30 years ago, but it speaks to an important part of surgical epilepsy in the young patient, the patient who's an infant or young child, because the epilepsies that are associated with intellectual disability that develop at that age can end up compromising that child's development. And the sooner that the seizures are controlled, the more likely the child is going to have some regaining of that normal development, learning the things that all children are expected to learn in terms of language, coordination, social engagement. And so we know that before surgery and after surgery, which is what this bar chart shows from 1997, that communication, socialization, daily skills all improved after removing part of the brain. And that's a part of epilepsy surgery that astounds people when they first learn about it. And there's a quote actually from a neurosurgeon from prior generation, Rasmussen is his name, that bad brain is worse than no brain, meaning that brain tissue that's causing seizures in a developing child, a child who's not reached their cognitive development of an adult, will compromise that development. And so removing that allows for the tissue, the brain that's not causing the seizures, to follow its normal course, to gain the skills that you would want all children to gain. So I would consider urgency, the hallmark of all urgency, to be when you can provide an improvement in development, which is a lifelong benefit to that child. We only have a window of time to learn the things we learn. A child who doesn't have gained language in early childhood is going to have a very hard time learning language later on because the brain development doesn't allow it. And that's another reality of how brains develop after we're born. So I said earlier that surgery should be considered when medications fail, and surgery should be considered when it's superior to medications. And so we don't have the highest level of evidence across the board for all surgeries about that superiority, but we do have that for the condition mesial temporal lobe epilepsy, the epilepsy which arises from the inner side of one of the temporal lobes. This is now a 20-year-old study, but it was a landmark, a milestone. And it was people with temporal lobe epilepsy, 80 people, who were evaluated for surgery. They were enrolled in the study at the time of the evaluation, and they were checked a year later. And those who were randomized, who agreed at the beginning to be put into either a surgical or medical group, those who were assigned to medication for that year had an 8% chance of being seizure-free. Those who were assigned to the surgery arm had a 58% chance of being seizure-free. And so this led to an improvement in those who had surgery, well, those who were assigned to the surgical group. But for part of this that might be surprising, this is what's called an intent to treat trial. That's a standard type of trial in medicine. That means people are assigned to groups with the intention, the plan that they should have the treatment. Doesn't mean they actually get it. And so the study was really seeing whether people should be evaluated for surgery, not whether they should have it. And if you looked at those who actually got the surgery, 64% were seizure-free. So the difference between the 58 and the 64 is some people were in the evaluation for surgery, but it was considered that surgery would not help them, so they didn't get the surgery. The point of the study was to see whether people should be evaluated. And if being evaluated led to a higher rate of seizure freedom, especially if you actually got the surgery, because of the people who actually got the surgery. One person died, tragically, in the medication arm. No one died in the surgical arm, which these are small numbers, but it's what I'll get back to in a moment, shows that any surgery carries realistically a fear. I mean, no one wants to have surgery. I think no one should want to have surgery. The question is whether surgery is safer than not having surgery. And this is one part of the evidence that for the person who's a candidate for epilepsy surgery, it can be safer than not having it. The question then is how soon? The study I just showed you was followed up by another study, which was the early randomized study, which looked at people who had had what looked like mesial temporal lobe epilepsy for fewer than 2 years. So earlier in the course than is typical. Because what's typical is about a dozen years of poorly controlled seizures before people start thinking about surgery. So the idea was to step in earlier and found that 11 out of the 15 in the surgery group and no one in the medication group were seizure-free at 2 years. A longer follow-up period, but again showing superiority and improved quality of life for those who had surgery for this type of epilepsy. And so this speaks to the outcomes as well. How do we judge outcome over what period of time, which is an important part of the thinking about how soon to do it. And so we know across other forms of surgery that the outcomes are high. The anterior temporal lobe resection you see here relates to mesial temporal lobe epilepsy we just talked about. And in this study, about 88% became seizure-free. So higher than 68, and it's different studies show different things. The question is, how does it compare to medications? And that goes back to that definition of drug-resistant epilepsy, where the likelihood of medication succeeding for this type of condition is a few percent. It's not zero. You know, people do luck out, and that's great. The question is, where do you want to place your bet? But then the question then is long-term outcomes. What happens a year later, or here 14 years later? This is a group of people who had epilepsy surgery across different types, looking at the success over time. And unfortunately, the success in the first few years is not going to be the success after 14 years. And you can see that I'm looking at 10 years. About twice as many people were seizure-free at 10 years on this chart. You can go across the bottom and see the number 10. The teal bar is about twice the height of the crimson bar. These might be the right color names, I'm not sure. And so again, showing the superiority of the surgery for these groups, but overall, I mean, let me point out the decrease is because you have fewer people over time, that people disappear so we don't know what happened to them. But the success is enduring, but it's not complete. And that's where we are at the frontier of trying to continue to improve the outcomes. This study looked at mortality, death, looking at people who got epilepsy surgery and those who didn't. And those who did not get surgery had a higher likelihood of dying. You know, the ultimate bad thing to happen compared to surgery. And so part of that decision about how soon comes down to what are the upsides, what are the benefits? And if one benefit is staying alive, that should be part of the consideration toward moving sooner. So I'm going to summarize what I've said because I haven't answered the question. I promised you I wouldn't answer the question. What I was hoping to do is sort of frame some of the thoughts around this. What is drug-resistant epilepsy? Well, it's a failure of appropriate medications. What's appropriate? Well, you got to make sure of that by talking to the doctor, whether the medication was the right one to use at the right dose and was working in terms of not causing side effects. What is a surgically treatable epilepsy? Well, one that's been found to be surgically treatable. It's circular. And this comes like most of medicine, where we end up knowing what works by seeing what works. But it has to come from a comprehensive evaluation. It comes from not just one MRI or not one EEG, but a comprehensive evaluation that includes multiple tests at a center that has experience in this. What is urgent surgical intervention? Well, I think that's when the surgery has a greater likelihood of working, and that person's time is important. Meaning, is that person at risk for a serious injury or an impairment, some kind of blocking of their development, their cognitive development, intellectual development, where waiting is going to create a lifelong consequence where not waiting can help limit that. And then successful treatment is the lack of seizures, no treatment-related problems, improved quality of life, and what I actually forgot to put down on the slide, which I'm now thinking over a long period of time. It's not a question how well it works for a year. It's a question how well it works for the rest of that person's life. And that's part of what has to be considered for when to move towards surgery. So that was my last slide. This is where I come from. This is a shot from UCLA's hospital. That's the neurology building. I like the tree. Just thought I'd end on something pleasant to look at after some talk about this. Thank you.
Okay. All right, so I have no disclosures, but I would like to say that I'm going to present 2 cases in parallel of patients that I met early, just after my training. And I have seen variations on these patients since then, and it really drives home why early surgery is better. So first I'll start with someone that I'll rename Curtis. He was a 7-year-old male, had epilepsy since the age of 3, was said to have generalized tonic-clonic seizures. He initially had 3 per year, and then it escalated to 1 per month. He tried 1 anti-seizure medication previously. When I met him, he was taking 2 every day, valproic acid, levetiracetam. Meanwhile, almost at the same time, someone I'll call Raj came in. He was 8, about the same age, had epilepsy onset at age 5, also was said to have just generalized tonic-clonic seizures. Initially, he had had 1 per week for a month, and then none for a year, and he was having 1 per month when I met him. He was taking 2 ASMs, lacosamide and lamotrigine, already at maximal doses. Going back to Curtis, he came in for an EEG at one point, and they said, you know what, these seizures are actually secondarily generalized. They start in one part of the brain, probably in this left posterior temporal lobe. The MRI, though, is normal, and so his team had told him, you know, the next medication might work, and there's no clear target for surgery because your MRI is normal. So the valproic acid was increased, and he experienced weight gain. Seizures continued. So he was started on lamotrigine, and he experienced a severe rash. Meanwhile, Raj has a video EEG, has seizure capture, no focality at seizure onset. But review of the video of him sitting there when the seizure started showed a behavior change before he had the generalized tonic-clonic seizure. His MRI, also normal. His parents were told that his seizures appear to be focal at onset, maybe not on the EEG, but in what we're seeing. More evaluation should be done. They are told that his chance of finding a medication that will result in seizure freedom is very low at this point. And they arrange admission for pre-surgical evaluation. Curtis, meanwhile, is admitted because of this severe rash. He started on oxcarbazepine, valproic acid's continued. He remains on levetiracetam. He's discharged once the rash appears to be getting better, but his seizures continue 1 to 2 times a month. His parents are increasingly worried about aggressively treating his seizures with meds at this point. Very distraught. Meanwhile, Raj comes in for his pre-surgical evaluation. Video EEG is done. Extra electrodes are put on in the area that we think that the seizures may be coming from, and we see in the left parietal lobe, yep, there's onset there. High resolution MRI is done, along with a functional MRI to help us know where his language, his vision, his motor systems are. And a PET scan is done to show where the seizures may be starting in a different way. And it also shows there's an abnormality in the left parietal region on the PET. Meanwhile, Curtis, within a month of discharge from his admission, he's gained 10 more pounds. He continues to have seizures. During a seizure, he falls, chips his front teeth, sustains an eyelid laceration, just barely missing the cornea. His oxcarbazepine is increased. He stays on valproic acid and levetiracetam. Meanwhile, our epilepsy surgery team meets and discusses Raj's care. We look at his EEG, we put his MRI and his fMRI and his PET, and we co-register them all in this 3D model, and we say, look, you know what? We need to offer you a stereo EEG so we can actually identify where the margins are of this area that we see that's abnormal, that we know your seizures are coming from. Going back to Curtis, 3 weeks after his big fall, he has a seizure while sleeping, and the parents find him in the morning convulsing. They call 911. They don't know when the seizure started. So they don't know how long it even lasted. He gets IV meds. Eventually his seizure stops. He's discharged 2 weeks later on levetiracetam, valproic acid, fosphenytoin, lacosamide. He's tired, understandably sad, that he can't be like what he would call his normal friends, and he's now 45 pounds over his ideal weight. Meanwhile, Raj has his SEEG scheduled in the next month. He has seizures in the interim waiting for this, despite us adjusting medicines. He's having stomach aches, and he really hates taking his medicines. Curtis has been absent from school so many days that he has to repeat 3rd grade. In class, one day he has a seizure and he hits his head on a desk. The parents actually remove him from school and say, you know, you can't take care of my child. I need someone to be there all the time. It's not safe. And they're afraid of having more falls when they can't be there to catch him. So by the age of 10, he's 60 pounds overweight, and he uses a wheelchair for transport to avoid multiple seizure injuries and to prevent his parents from having to pick him up off of the floor, because they're a bit older and they couldn't manage to do that safely. Meanwhile, Raj undergoes stereo EEG, which delineates a small abnormality in the left parietal area, and he undergoes thermal ablation of that region. He's weaned off one seizure medicine a few months after surgery, and 2 years later, he's still seizure-free, and so he's weaned off the last one by the age of 10. It doesn't end there. Curtis goes on to suffer more seizures, medication side effects, including worsening memory. He doesn't receive a high school diploma. Around the time he's 21, his seizures change and they look very focal, they look different. An MRI is done. This time it's abnormal, and it shows an abnormality in the left hippocampus, which is actually secondary to recurrent seizures from probably the area in the posterior temporal lobe, which actually is still active on EEG as well. So he continues to have seizures once every 6 weeks and now lives in a facility because his parents couldn't safely care for him at home. Meanwhile, Raj did well in junior high and high school, got average grades, struggled with anxiety and attention, but his seizures never came back. His parents got him into school-based counseling and to see an old neurologist to discuss attentional issues. And he graduates and attends college as far away as he could get from home. And he never had another seizure. And so I think I'll go ahead and end here so that we can have some time for questions. But these are two cases that I see frequently, and I see everything in between, and I think there are many reasons why people don't go into surgery and don't go into surgery sooner than we would like them to. The biggest is probably the fear of the actual surgery. Getting information from sources, really you need to have reliable sources, and really looking at a comprehensive epilepsy team is really important to get that information. Pre-surgical evaluations can be very slow. They can be confusing. You need somebody to be able to tell you several times over and over in plain language what you're doing and why you're doing it. And if you don't understand, you need to ask them again. And if you still don't understand, you need to ask someone else, maybe another physician, for a second opinion. And so I think to end, what I would say is not only do we see seizures change the trajectory of someone's life, but it's just like John said, we see IQ points drop, we see IQ points improve if the surgery is done within 3 years of seizure onset. Those are where it's more likely to improve. And so there are a lot of long-reaching effects that happen with surgery. And so the sooner we do it, I feel the better off that we are. And so if you're not getting good answers from your group or your physicians, I always encourage my patients to get a second opinion if they're not comfortable, because that can really make sure that they're on the right path. So we'll end there, and just so we can get to some questions.
Wonderful, thank you so much. We have about 5 minutes for questions. Does anyone have any questions today?
I'm trying to formulate my question, but because we're about to have our meeting, we just did the EEG in the hospital to evaluate for it. They think she's a good candidate. Sorry, that's her. Anyway, she right now is, hi. Anyway, my question is, so she's 18 now, she is intellectually disabled. I'm not going to force the surgery on her, which I need this, so I guess this is more of a comment. I need this in her language. And this is going to be a process, because there's no way I'm going to force surgery on her, and we need a way to go. And I don't know who the person is who puts that into her thinking we're giving her as much time as she needs. That's our plan, to think about it and ask the questions she wants. But this is exactly what I've been thinking about it. Yeah. It's just I now need to do the very delicate dance of working with her to make it her decision, because she's still a normal 18-year-old.
Right.
Who doesn't want to do anything her mother wants to do. So
yeah. I know, and that's where I think, hopefully you have some providers that can help talk with her, but sometimes, I don't know, sometimes us physicians aren't always the best, but we need to try to be. And sometimes we have social workers or coordinators that do even a better job in talking with the children. But I really love talking with children and sitting down and showing them electrodes and showing them devices and talking about surgery, and then having them talk to another family, maybe a child similar to her, to understand a little bit more about what the experience was like for that other child. Yeah.
I stood up to say that sometimes having another patient speak to a patient is helpful, because it's not the mother, it's not somebody who's so close, but it's somebody who's gone through it, who can speak what it's like on the other side.
So I have a question. What happened with Curtis was the child who didn't have the epilepsy surgery in your example, right?
Mm-hmm.
Where did the failing take place?
Yeah.
Like, is it because it was missed on imaging and the team didn't recognize the drug resistance and didn't address that? Was it the parent resisting? Like, where do you think the biggest barriers are? Like, was this at your center? Were these
Right.
those patients you saw?
So we actually met Curtis later when he was already wheelchair bound. And so, and it wasn't too, it's never too late. That's the thing. We, said we can actually still help. But it was problems on both sides. It was him not being at an epilepsy center in the beginning, and then the parents really becoming more and more protective, understandably, that they weren't getting good options, and all the physicians were doing were increasing meds. But and so there were issues on both sides, and that's really the most common scenarios I see, is that the providers weren't communicating well. Maybe they didn't know enough, but they're not communicating well. The parents are frustrated and scared, and don't know how to navigate as well. So it's so complicated and different for everybody, but
We'll take one last question.
What are your statistics on adults having the surgery? Let's say you kind of exercised all your options on max meds. He has a VNS implant currently, and they're saying he's not a candidate. But how does that affect, like you're saying, to catch it early on?
For adults, the point of the surgery is to decrease the seizures, eliminate the seizures, decrease the risk for injury, improve quality of life. But what makes somebody a candidate is when the evaluation shows that a surgical treatment is likely to produce the seizure freedom. And so the evaluation can lead to an estimate for that. And the details of the evaluation is what produces that estimate. So it's all over the place, where when the likelihood is low, then the judgment is it's not worth the risk of a surgery. And other treatments could be helpful, including the neurostimulation devices like VNS or the other two. So the answer to your question is it's all over the place in terms of possibilities, and knowing what it is how you make your decision.
Thank you very much.